patient comes to you with sleep issues, where do you even start with the assessment? So last week we talked about the CSH framework, which I recommend using for every single patient who comes to you with sleep issues. It's even helpful for patients who don't have sleep issues, so you can check out that video after you watch this one. But today we're going to look at some basic screening labs and basic blood tests that you can do as part of your initial workup of sleep issues. If you're a physician or a therapist who wants to up-level your sleep medicine knowledge, then go ahead and subscribe to this channel. Also click the like button. Doing so helps to feed the YouTube algorithm, which helps a small channel like mine get out to more people. If you find this content helpful, I also encourage you to share it with other clinicians, physicians, therapists who could benefit, because most of us only get about 2 hours of sleep medicine training in medical school, but all of our patients have to sleep. I'm Dr. Nishi Bhopal. I'm a physician specializing in integrative psychiatry and sleep medicine, and this channel is all about clinical, practical sleep medicine for your outpatient practice. You can get CME credits, so watch all the way to the end and then grab your CME. The link is in the video description below. Just a quick disclaimer, the information that I'm presenting here is information only and is not medical advice. We are going to be talking about some screening tools and labs that you can do as part of your initial workup for a patient with sleep issues. So the list that I'm going through, the screening tools and the labs, are not comprehensive. These are just a starting point, and they're pretty easy and accessible, so you can easily order them and use them in your practice. They're accessible for patients, so that's why I'm recommending these ones to start with. I also want to mention that you don't have to order labs to be successful in helping a patient with sleep issues, but if you are able to do labs, then they can be a really useful tool for your assessment and for tracking purposes. Let's start out with 2 rating scales that you can use starting today in your clinical practice if you're not already using them. These are the Stop-Bang questionnaire and the Epworth sleepiness scale. Are you already using either of these in your practice on a regular basis? Go ahead and let me know in the comments below. The Stop-Bang questionnaire is a screening tool for sleep apnea, and my view is that every single patient that you see should be screened for sleep apnea. Sleep apnea is one of these things that is underdiagnosed, especially in certain populations like in women. We often think of the classical archetype of the overweight male with the 17-inch neck with loud snoring as the picture of sleep apnea, and yes, those patients can have sleep apnea, but you can also find sleep apnea and sleep disordered breathing in patients that you might not think of, like in thin patients, in women, in children, especially if you're a psychiatrist like myself. If you're seeing patients with depression, anxiety, treatment-resistant symptoms, we need to have sleep apnea on our radar. And of course, patients with sleep issues and insomnia should also be screened for sleep apnea. So you can use the Stop-Bang questionnaire as one of your initial screening tools. The Stop-Bang questionnaire is a screening tool that you can use for sleep apnea. It's a rating scale. It's readily available, quick and easy to fill out for your patient. It is sensitive, but it's not specific, and it might miss symptoms or give you a false negative in certain patient populations, like in women, in Black patients, and patients who are thin. So I want you to take that into consideration when you're reviewing the results, but it's just a nice simple tool that you can start incorporating right now, even to get your patient thinking about some of the symptoms. Of course, in conjunction with doing this, you want to take a really good history. A Stop-Bang questionnaire alone is not enough to screen for sleep apnea. And as I was mentioning before, you really want to consider sleep apnea in patients who have other comorbidities, so things like uncontrolled hypertension, cardiovascular disease, treatment-resistant depression, and things like this. So we really need to have this on our radar. The next screening tool that I recommend that you use for all of your patients is the Epworth sleepiness scale. All patients who come into my private practice get an Epworth sleepiness scale as part of their intake packet. So this is a way to assess for excessive daytime sleepiness. Score more than 10 indicates excessive daytime sleepiness. You'll find that patients who struggle with insomnia tend to have very low scores. They might just give you a score of 1 or 2 because they have so much hyperarousal that their levels of sleepiness have decreased. But this is a really useful tool to use in your practice just to get a sense of what your patient's day-to-day levels of sleepiness look like. If this type of information is helpful for you, I'd like to invite you to get my free sleep mini course called Sleep Medicine Pearls for Outpatient Doctors. It's filled with lots of practical tips and tools that you can use in your clinical practice right away. So if you're an outpatient doctor or therapist and you ever see patients who complain of sleep issues, you need to get this course. It's totally free. You can get CMEs. You can sign up at intrabalance.com/doctors. The link is also in the video description below. In addition to the rating scales, you can also order screening labs as part of your sleep assessment. Here I've listed some of the common ones that you can start with. Again, you don't have to do labs as part of your sleep assessment, but if it is within your scope of practice, it can be really helpful data to have. I usually start with some basic things like a CBC, a CMP, thyroid panel, hemoglobin A1C, lipid panel, and then looking at micronutrients as well, specifically your iron studies and ferritin, vitamin D, B12, and folate. So let's look at a few of these in a bit more detail. detail, starting with iron. There is an association that's been shown between decreased iron intake and very short sleep of less than 5 hours. Iron, of course, is implicated in restless leg syndrome, or RLS. It's involved in dopamine dysfunction. Iron is a cofactor for tyrosine hydroxylase, which is the rate-limiting enzyme in dopamine production. I screen for low iron in the vast majority of my patients, whether they're struggling with low energy and fatigue or insomnia, disrupted sleep, of course, if they have symptoms of restlessness or restless leg syndrome. Also for patients who are struggling with anxiety and depression, mental health issues, I have a pretty low threshold for screening for it. More often than not, I usually do find some kind of either suboptimal iron or iron deficiency anemia. So when checking iron, you want to check a full panel, including a CBC, ferritin, iron, TIBC. You don't want to be checking ferritin in isolation. Ferritin, as you recall, is an acute phase reactant, so it can be elevated in inflammatory conditions. You want to get a full iron panel to get a full picture of what their iron status looks like. If patients do have RLS symptoms, then it's recommended to supplement with iron if their ferritin is less than 75. You can learn more about how to check iron levels properly in my video on checking iron levels, or you can go to the Restless Leg Syndrome Foundation website, and they've got lots of guidelines on checking iron and on iron repletion. The next thing I like to look at is vitamin D status. So vitamin D is involved in the circadian rhythm. It helps to coordinate the sleep-wake state. It's involved in serotonin and melatonin regulation. Some studies show that vitamin D supplementation may help improve sleep latency, and it may increase sleep duration in older adults. Vitamin D levels of less than 20 nanograms per milliliter are associated with poor sleep quality. The Endocrine Society recommends repleting vitamin D levels if the levels are less than 30. Some studies suggest that an optimal level is around 40 to 60. More studies are needed to determine what the optimal levels are. In my patients, I usually aim for a level of between 40 and 60. Then we have vitamin B12. B vitamins are important cofactors in a variety of different enzymatic reactions, including the conversion of tryptophan to serotonin to melatonin. When looking at a vitamin B12 level, the optimal level is in the upper half of the reference range, so that's what we're aiming for. You want to check B12 levels in certain patient populations. I do check it in the vast majority of my patients because I see a lot of patients with fatigue, depression, anxiety, insomnia, sleep-wake disturbances. So you want to be checking it in those patients, and also consider checking it in patients who are on proton pump inhibitors, on metformin, who are over the age of 60, who are on a vegan diet, or who have other risk factors for low vitamin B12. We go into more detail about all of this kind of stuff in my clinical sleep kit community. So if you found this kind of information helpful, stay tuned. As of right now, it's January 2024 at the time of this recording. I'll be opening doors to the community in a few weeks in mid-February. And so if you are interested in connecting with others who are in practice and who want to learn more about sleep, who want to go into more detail on these integrative and holistic approaches, you want to interact with sleep experts from around the world, stay tuned. It's just so much fun. And so I'd love to welcome you into the community. Stay tuned for doors opening. And then I would love to hear from you if you're using any of these tools in your practice. If you're already using some of these rating scales or these labs, tell me in the comments below. Or if there's other things that I didn't talk about in this video that you have found helpful with assessing patients with sleep issues, I would love to hear from you. So drop me a note in the comments below. If you find this content helpful, I also encourage you to share it with other clinicians, physicians, therapists who could benefit, because most of us only get about 2 hours of sleep medicine training in medical school, but all of our patients have to sleep. I'm Dr. Nishi Bhopal. I'm a physician specializing in integrative psychiatry and sleep medicine, and this channel is all about clinical, practical sleep medicine for your outpatient practice.